Escalation to overt rejection represents a late-stage outcome of prolonged psychological control and attachment disruption. By the time resistance to contact becomes visible, the child's regulatory and attachment systems have already undergone significant reorganization. What appears externally as defiance, hostility, or refusal is more accurately understood as the culmination of unresolved anxiety, conditioned avoidance, and accumulated attachment injury. Resistance rarely emerges suddenly. Early discomfort around transitions gives way to anticipatory anxiety. The child begins to experience physiological arousal before contact tightness in the chest, stomach pain, headaches, nausea, or fatigue. These somatic complaints are not fabricated. They are expressions of autonomic nervous system activation in response to perceived relational threat. As psychological pressure persists, anxiety becomes more intense and less specific. The child may report fear without a clear cause. Panic-like symptoms can emerge during transitions or discussions of contact. The body reacts as if danger is imminent, even when no immediate threat is present. This response reflects learned association rather than situational reality. Avoidance becomes the primary regulatory strategy. Avoidance reduces physiological arousal. When avoidance is successful, anxiety decreases. This relief reinforces avoidance behavior. Anger and rage may also surface during this stage. These expressions are often misinterpreted as oppositional behavior or hostility toward the targeted parent. From a psychological standpoint, anger functions as a mobilizing response that creates distance from a perceived source of threat. Rage may also emerge when anxiety has been suppressed for extended periods and can no longer be contained. Importantly, these emotional expressions are often context-specific. The child may function well in other domains: school, peers, daily routines, leading observers to conclude that distress is situational or manipulative. This interpretation overlooks the fact that attachment-related stress can be narrowly triggered and compartmentalized. Refusal to contact is frequently accompanied by rigid justifications. The child may offer categorical reasons that lack proportionality or experiential grounding. These explanations often mirror previously internalized narratives and serve to rationalize avoidance. The function of the explanation is stabilization, not communication. At this stage, the child's behavior is often misdiagnosed, or mood disorders may be assigned as primary explanations. While symptoms may meet diagnostic criteria, these diagnoses frequently mistake manifestation for origin. The underlying driver is relational conditioning, not intrinsic psychopathology. Misdiagnosis can be particularly harmful because it redirects intervention toward symptom management rather than mechanism. Treating anxiety without addressing the attachment context leaves the conditioning intact. In some cases, interventions inadvertently reinforce avoidance by validating refusal as protective without examining the relational contingencies shaping fear. Somatic symptoms are especially prone to misinterpretation. Medical evaluations may find no organic cause, leading to frustration or dismissal. Yet these symptoms are consistent with chronic stress responses. The child's body is expressing what the child cannot articulate safely. As rejection consolidates, the child's emotional range may polarize. This polarization reflects compartmentalization rather than global dysfunction. The transition from avoidance to refusal marks a critical shift. The child is no longer merely regulating internal distress. The child is actively preventing exposure to triggers associated with attachment conflict. From the child's perspective, refusal is not defiance. It is self-protection. Institutional responses at this stage often intensify the problem. When systems treat refusal as evidence of preference or pathology, they validate avoidance and solidify the child's belief that contact is unsafe. Pressure applied without altering underlying contingencies increases distress and resistance. Understanding escalation to overt rejection requires recognizing temporal sequence. Anxiety precedes avoidance. Avoidance precedes refusal. Refusal precedes detachment. Each step reflects adaptation to unresolved relational threat. Crucially, overt rejection does not indicate resolution of attachment injury. It indicates that the injury has become intolerable to experience consciously. Detachment may follow as a final defensive step, reducing emotional pain by severing connection. From a developmental perspective, the cost of this trajectory is significant. Chronic anxiety, somatic distress, emotional dysregulation, and distorted relational expectations can persist long after the original context is changed. Interpreting overt rejection accurately requires moving beyond surface behavior. The presence of panic, somatic symptoms, rage, or refusal should prompt inquiry into conditioning history, attachment dynamics, and emotional contingencies rather than immediate attribution to individual pathology. When escalation is understood as the endpoint of psychological control rather than as a spontaneous disorder, the child's behavior becomes intelligible. The child is not rejecting a parent because of preference or pathology. The child is avoiding a relational context that has become associated with overwhelming internal threat. Until that threat is addressed at its source, symptoms will persist, shift, or intensify. Overt rejection is not the beginning of the problem. It is the signal that earlier mechanisms have gone unrecognized for too long.